So we need to move on to our next speaker, Dr. Mohammad Qadura, who will be talking about fatty acid binding protein 3 is associated with peripheral arterial disease, presenting from St. Michael's Hospital in Toronto, Ontario. Dr. Qadura.
Thank you so much. So thank you once again for this great opportunity and the privilege to speak to everybody. In summary, today I'll be chatting to you about how my research team is very keen on proposing that fatty acid binding protein 3 could be utilized as a potential biomarker for PAD. To do so, we constructed this pilot study in a case control fashion on 75 patients with PAD as well as 75 patients without PAD. We measured the plasma levels of FABP3 in these patient populations, and in addition to localizing FABP3 expression within skeletal muscles isolated from patients with peripheral limb ischemia or basically healthy individuals. In order to dig into details, we'll go over a few slides. And once again, this is me, and I'm presenting on behalf of my very productive research team here in Toronto, Canada. First, I would like to announce that I have no disclosures. I believe that everybody in the audience knows how bad peripheral arterial disease is. Unfortunately, it's just like the middle child. It's not well, doesn't deserve the attention it seeks. But believe it or not, peripheral arterial disease is a major problem, not here in North America only, but globally. Almost 150 million individuals suffer from PAD globally, which is roughly the sum of both patients suffering from coronary artery disease or carotid vascular disease as well. In North America, we have almost 15 patients with PAD. At least in Canada, but I do presume similar numbers in the US. Unfortunately, many patients go undiagnosed, or basically they get diagnosed late in their disease status. And there's a significant pathophysiology behind this, which we will not go into details. But as healthcare providers, unfortunately, we see the front end of these complications. In Canada, the average cost for the annual hospitalization of patients with PAD is roughly about $5,000. And an amputation on annual basis costs our healthcare system about $70,000. So it's a major problem on the patients, in addition to us as healthcare providers on the healthcare system, and it's a big problem since it's global and it's poorly diagnosed. Our group, in addition to others, run basically a couple of surveys to learn on why this is a major issue, and it stems from the diagnostic tools that we have. Most of the diagnostic tools that is available for physicians, mainly either radiographical based or in addition to clinical exam. The ankle brachial index is the most simple form on how we can diagnose patients with PAD. And unfortunately, we do not have a blood-based biomarker yet. We run a couple of surveys just to learn on why this is an issue. We learned that in order to conduct the most simplest form to diagnose patients with PAD, which is the ABI, it requires extensive staff training. It's usually unreliable in some patient populations with diabetes, especially if they have non-compressible ABIs. It's time consuming, and there's limited centers which can actually afford this diagnostic test. So we wanted to propose a specific marker for PAD, and we thought, let's think backwards. So we did some proteomics and tried to basically identify the proteins that are mainly expressed within skeletal muscles, and we stumbled across fatty acid binding protein 3 while we were doing our mass spectrometry analysis. We learned that FABP3 belongs to a multi-family of fatty acid binding proteins. It is almost over 95% expressed in skeletal muscles as well as cardiac muscles, very minimally in other tissues. And it's mainly an intracellular protein that's not usually present extracellularly, but it gets released after basically an insult to the muscle, whether it's ischemia, injury, etc. So we thought it might be a good candidate to work with. So our hypothesis was, can we use FABP3 as a marker for PAD, and is it elevated in this patient population? So this will be the first step, and this will be hopefully my dream before I retire, in introducing the ACS equivalent the troponin in this patient population. So we need a blood-based marker to diagnose our patient population. So could FABP3 be this troponin ACS equivalent? To do so, we ran this trial at St. Michael's Hospital here in downtown Toronto. It was in a case-controlled fashion. Within a year, we recruited 75 patients with PAD, in addition to 75 patients without PAD. We also recruited 3 patients with chronic limb-threatening ischemia, where we isolated skeletal muscles from those individuals. in addition to 3 other individuals without peripheral arterial disease, which we were able to get muscle biopsies from the skeletal muscles. With such a design, we were able to measure the levels of FABP3 within blood vessels, in addition to localize the level and expression of fatty acid body protein 3 within skeletal muscle. So as you can see, on this slide, basically, we have the patients with and without PED, and it goes without saying that patients with peripheral arterial disease usually have significant cardiovascular morbidities, just like hypertension, hypercholesterolemia, diabetes, and almost every single variable that we measured was significantly elevated or worsened in patients with PED relative to their counterparts. So the most simple experiment we did is basically measure the levels of FABP3 in this patient population. I also would like to say that we also co-measured the level of troponin I in these individuals, just to ensure that troponin I is not elevated, because as I mentioned earlier, fatty acid binding protein 3 is also released by the myocardium. We just want to make sure that the observed level of FABP3 is elevated due to other sources within the skeletal muscles, but not the myocardium. We noted that in patients with PED, the levels are significantly elevated. It's almost 3.9 nanograms per milliliters relative to patients without PED, which is about almost 2.27. Since we had a small sample size, about 75 patients per group, we could not really do very in-depth statistical analysis. However, we've done some subgroup analysis. As you can see on this slide, on the x-axis, you have basically the disease of the confounding factors we'll have to study, which is coronary artery disease on this side, and diabetes on this other side. On your y-axis are the level of the fatty acid body protein 3. As you can notice in the bar charts, that the shaded groups are the num-pads, and the solid line is the pads, regardless of the background, whether they're diabetics or whether without coronary artery disease. The the level of fatty acid binding protein 3 was constantly elevated in individuals with a background of PED, regardless if they were positive or negative for coronary artery disease or diabetes. Next, we basically segregated our patients based on their severity, and we used basically the ankle brachial index as a gauge to help us identify the severity groups. So you have patients here on the x-axis of healthy, between ABI of 0.4 to 0.9, less than 0.4, and non-compressible ABI on your y-axis, the FABP3. And you can see basically the levels of the protein is elevated as the disease status worsened. Also, Spearman correlation analysis showed an indirect relationship between the levels of FABP3 and ABI, which makes sense that as the ABI is reduced, when it goes down, the levels of FABP3 goes up, demonstrating a negative relationship between ABI and fatty acid binding protein 3. Last, basically, we wanted to localize the level of the expression level of fatty acid binding protein 3, and to demonstrate that's also expressed within skeletal muscles. So I went to my colleagues in cardiac surgery, and we managed to get some appendages from the atrium after doing a cabbage. And of course, recruited 3 patients without PED, and we got those skeletal muscles from biopsies while we're doing managements for the varicose veins. In addition to patients with curriculum ischemia, who unfortunately required an amputation, we were able to get some muscle biopsies. On panels A, C, and E, it's basically your typical H&E staining. On panels B, D, and F, basically we stained for fatty acid binding protein 3. And as you can see, the levels of FABP3 were elevated in the myocardiocytes and in patients with chronic lymphocytic ischemia, as demonstrated with this little brown discoloration, and is barely not elevated in patients with non-PAD. So to summarize, we've demonstrated in this policy that fatty acid binding protein 3 is elevated in patients with PAD. There's an association between the disease severity and PED, and it's reflecting a negative correlation between FABP3 and the ankle brachial index, and it built basically the foundation for a larger trial that we're currently running in order to utilize this biomarker as a diagnostic marker for PED. With this, I would like to thank everybody for their attention. I'm happy to answer any questions if time permits. Thank you.
Just a quick reminder for people to please put their questions in the chat, which I will be moderating. So Dr. Qadura, You had, the average ages were very young in the non-PAD group. Did you have, I mean, was there any sense that there was any difference in terms of as patients got older, whether their FAB 3 levels went up?
Absolutely. As we also know that PAD is also a disease of age. Usually we tend to see it in patients who are a bit more older. In the largest trial that we concluded almost a year and a bit ago, where we have over 800 patients recruited, we were able to adjust and account for age. And we noticed actually there's a link between FABP3 and age. But despite of accounting for that in our subgroup analysis, we identified that it was basically not a major contributor to the levels that we observed.